Hi, I'm Doug Rex from Indiana University Hospital in Indianapolis, and I want to welcome you to a discussion of colonoscopy technique. This video is sponsored by the American Society for Gastrointestinal Endoscopy. The content of the video includes a discussion of informed consent, selecting the type of colonoscope, understanding tip deflection, anatomic landmarks in the colon, colonoscopic insertion technique, intubation of the terminal ileum, impact of sedation on technique, maintaining safety during colonoscope insertion, withdrawal technique, and finally, the very difficult colonoscopy. You can view these sections in sequence or select from this menu. A separate DVD covers polypectomy technique. In these discussions, I'm going to rely heavily on my personal experience performing colonoscopy and on the teachings of many well-known colonoscopists, on my personal experience with medical legal cases involving colonoscopy, and I'll refer to and defer to the published medical literature when possible. Let's get started. The first important question about informed consent is who should obtain it. A study of time utilization in Indiana and experience in medical legal cases indicate that there is variability across the U.S. with regard to who obtains the consent. In many practices, the endoscopist obtains consent, but in some practices, a nurse or other medical professional obtains consent. Therefore, there is no standard of medical care with regard to who obtains consent. My opinion, based on review of medical legal cases, is that the best situation for defense of a medical legal action is when the endoscopist has obtained consent and the patient remembers a clear-cut discussion of the risks with the endoscopist. It can also be useful to provide written material or a video for the patient to learn about the procedure and its risks. The issue of when consent should be obtained pertains to whether consent can be obtained in the open access process on the day of the procedure. There's a trend of regional variation in the U.S. regarding whether endoscopy units use closed access or open access. Closed access refers to when patients are routinely seen in consultation by the endoscopist prior to and on a different day than when colonoscopy is performed. Closed access is relatively common on the coasts of the United States, whereas open access is more common in the central part of the country. Open access means that some patients are scheduled for colonoscopy and appear prepped in the endoscopy unit without ever having met the colonoscopist. In this setting, informed consent will be obtained by the endoscopist immediately prior to the procedure. Open access is sufficiently common in the U.S. that we must conclude that the standard of medical care allows for informed consent to be obtained on the day of the procedure. The specific risks that should be mentioned include perforation, along with the likely need for surgery if perforation occurs, the possibility of a missed lesion or cancer, bleeding, and medication reaction. Colonoscopists should consider discussing the risk of splenic injury. From a medical legal perspective, perforation and the possibility of missed lesions should be emphasized, since these are the two complications most likely to result in a malpractice suit. Splenic injury may result in a malpractice suit if its management requires splenectomy. If you know your own perforation rate, you can quote it. If you don't know your own perforation rate, studies show the overall perforation rate in the United States Medicare population for colonoscopy is still about 1 in 500, although it's somewhat less than 1 in 1,000 for screening cases. Many experienced colonoscopists have a perforation risk of 1 in several thousand for screening colonoscopy. Screening means doing colonoscopy in asymptomatic people to look for neoplasia, and asymptomatic people are less likely to have an abnormal colon that would increase the risk of perforation. A major deficiency of colonoscopy as a diagnostic, surveillance, and screening test is that the procedure is highly operator dependent. Several studies have shown that general surgeons and primary care physicians performing colonoscopy are more likely to fail to detect colorectal cancer than are gastroenterologists. This difference suggests, but does not prove, that training and detection is associated with better protection against colorectal cancer. The specific elements of training that lead to better detection have not yet been defined. However, even within members of the same gastroenterology group, it's been repeatedly shown that detection of adenomas is highly variable. The next slide shows that detection of proximal serrated lesions is even more variable. This means that some gastroenterologists miss the majority of adenomas in the colon during colonoscopy, miss the majority of advanced adenomas, miss the majority of serrated lesions in the colon also. Since 2002, guidelines have recommended that colonoscopists measure the quality of mucosal inspection by measuring the adenoma detection rate. The adenoma detection rate is defined as the percentage of patients age 50 and older undergoing their first screening colonoscopy who have one or more adenomas detected. The recommended threshold for adequate detection is at least 25% of men and at least 15% of women should have one or more adenoma detected. The true prevalence of adenomas in the population is considerably higher than these thresholds, as demonstrated by repeated studies showing overall adenoma detection rates in the 40 and even 50% and higher range using high-definition colonoscopes. In a study from Poland of screening colonoscopy, doctors who had adenoma detection rates below the recommended threshold for a mixed-gender population of 20% saw their patients have hazard ratios for the development of cancer that were more than 10 times those of patients who had undergone colonoscopy by doctors with adenoma detection rates above 20%. Thus, measuring the adenoma detection rate is a must for every colonoscopist and is a validated measure of the quality of mucosal inspection. Several recent studies have demonstrated that colonoscopy is less effective at preventing cancer on the right side of the colon compared to the left side of the colon. In the best studies, protection rates on the right side are in the range of 50 to 60%, while they exceed 80% in the distal colon. Several reasons have been proposed for why right-sided protection might be worse. First, some doctors have lower rates of cecal intubation, and some may say they have achieved cecal intubation when they have not. Thus, current guidelines for colonoscopy quality recommend minimum thresholds for cecal intubation and recommend documentation of cecal intubation by notation of landmarks in the cecum and photography of visualized landmarks. Second, bowel preparation tends to be worse on the right side of the colon than the left side. This discrepancy in bowel preparation can be overcome by using either split dosing or same-day dosing of bowel preparations. Split dosing refers to giving half the preparation the evening before colonoscopy and the other half on the morning of colonoscopy. Split dosing counters the tendency of the right colon to have adherent mucus and small intestinal secretions when the interval between completing the preparation and performing the colonoscopy is too long. For patients scheduled for afternoon colonoscopies, ingestion of the entire preparation on the morning of the examination is associated with better quality preparation and may be more convenient for patients than split dosing. A third potential explanation for less protection on the right side of the colon is that lesions that are endoscopically subtle, including conventional adenomas that are flat or depressed, as well as serrated lesions, including hyperplastic polyps and sessile serrated polyps, are more common in the proximal colon and may be missed more often. Thus, the modern colonoscopist must be trained in the recognition of the full spectrum of precancerous lesions in the colon. Finally, the biology of colorectal cancer is different in right-sided compared to left-sided cancers, with more right-sided cancers demonstrating hypermethylation and/or microsatellite instability. This may result in some instances in a more rapid conversion through the polyp cancer sequence. In other words, a different biology in right-sided cancers compared to left-sided lesions. An important emphasis of this video and the accompanying video on polypectomy will be colonoscopic technique and technologies that minimize the chance of a missed lesion. Nevertheless, in the informed consent process, missing must be discussed because the consequences of developing cancer shortly after colonoscopy may be very serious for the patient. And whether such a cancer was the result of missing or not, it may result in medical legal action. The largest tandem colonoscopy study found that the miss rate for adenomas 1 centimeter and larger was 6%, and 2 CT colonography studies from Centers of Excellence have measured the miss rate of optical colonoscopy for adenomas 1 centimeter and larger at 12% and 17%. Endoscopists typically do not know their miss rates. They should be able to respond to patient queries about their skills in mucosal detection by giving their personal adenoma detection rates. It is perfectly reasonable for a patient contemplating colonoscopy to ask their potential colonoscopist for their adenoma detection rate. There also should be a discussion of the risk of bleeding, which is essentially confined to polypectomy, reaction to the sedative medications used, and there should be an opportunity to ask questions. Here's the whole process as I do it. So we've decided that we need to do a colonoscopy. It's indicated, but I want to make sure that you understand that there are some risks to the procedure. So first of all, we're going to sedate you. We want you to be comfortable. The risks of that include a small chance of dropping your blood pressure or having a change in your vital signs, including not breathing deeply enough. We're going to be monitoring all of that very closely. We're experts at taking care of any problems that might arise. Also, because you'll be sleepy, there's a slight risk of getting something down your windpipe, what we call aspiration, which might result in bronchitis or pneumonia. That chance is very small, less than 1 in 1,000. The risk of perforation, making a hole in the colon, it's a very serious thing. It can be bad enough to require surgery to fix it, is 1 in several thousand or less. If I take polyps out of your colon, these little growths that can turn into cancer, there's a chance of having bleeding. It's primarily present if we run into a large polyp. Those, of course, are the ones that are most important to remove. That can happen anytime in the first couple of weeks after the procedure. After the procedure, I'll be able to give you an idea of whether I think there's any significant risk of that based on whether we find polyps and how large they are. We say that colonoscopy is the best test available to look at the colon, but it's important to understand that it's not perfect. Rarely it can miss something, including something significant. Finally, it's possible but very rare for colonoscopy to injure the spleen. And there have been reports of injury that's been severe enough that it actually required surgical removal of the spleen. I think the chances of that are extremely small, but I just need for you to know that. Okay, any questions for me?
I don't think so.
Okay. An injury that was seldom recognized during colonoscopy 2 decades ago, but is now seen with increasing frequency, is splenic injury. The mechanism by which splenic injury occurs during colonoscopy is uncertain, but it is assumed that complex loop formation during colonoscopy results in tension on the splenocolic ligament that leads to laceration or avulsion of the capsule with bleeding from the spleen surface, or laceration with bleeding or formation of an intrasplenic hematoma. Diagnosis is often delayed and typically presents with left-sided abdominal pain, sometimes pain in the left shoulder, known as Kerr's sign, and can present with shock. Patients who are hemodynamically unstable may require splenectomy, and these patients may bring a malpractice action. Risk factors for splenic injury include female gender and possibly factors such as deep sedation, cigarette smoking, and prior abdominal surgery with adhesion formation around the spleen. However, only female gender is established as a definite risk factor, with about 3/4 of reported cases occurring in women. There is no established rule for how to avoid splenic injury during colonoscopy. My anecdotal recommendation is to be cautious and gentle with application of torque when the colonoscope tip is proximal to the splenic flexure and there are loops in the instrument. By insertion tube selection, I am referring to the choice between an adult or standard diameter insertion tube and the narrower pediatric insertion tube. For routine cases, the selection between these devices is, I believe, purely a matter of personal preference. The standard insertion tube has the advantage of being thicker and stiffer and therefore less likely to cause looping during insertion, particularly in the transverse colon. In my experience, standard insertion tubes are associated with about a 20% reduction in the need for ancillary maneuvers such as abdominal pressure during insertion. They also have larger working channels, typically at least 3.7 millimeters, and therefore suctioning is faster. Suctioning can continue when there are devices in the insertion tube, and they are better able to suck polyps back through the channel and clots in the case of lower gastrointestinal bleeding. The thinner pediatric insertion tube is more flexible and therefore on average will result in less pain because it generates less force in stretching the mesentery. The super or ultra-thin colonoscopes have diameters that are similar to upper endoscopes and may further decrease the tendency toward pain during insertion relative to pediatric colonoscopes. You may be aware of studies showing that flexible sigmoidoscopy pain can be reduced by using thin upper endoscopes to perform flexible sigmoidoscopy. Thus, upper endoscopes, which are sometimes used to perform colonoscopy in patients with angulated sigmoid colons, are even thinner than pediatric colonoscopes, generate very little force on the mesentery, and therefore produce less pain. Pediatric scopes are also very useful in passing strictures. About half the market in colonoscopes in the US is for pediatric scopes, indicating that many colonoscopists prefer pediatric scopes for routine use. In passing a stricture or sharp angulation, it should be remembered that even a small reduction in diameter can produce a substantial reduction in the cross-sectional surface area of the colonoscope tip, which is the critical determinant of ability to pass the stricture or angulation. Thus, moving from a standard insertion tube to a pediatric insertion tube is associated with a 1.5 millimeter reduction in diameter, but a 22% reduction in surface area. Moving from a pediatric colonoscope to an upper endoscope is associated with another 2.7 millimeter reduction in diameter and a 42% reduction in surface area. Finally, a thinner insertion tube can be successful when a larger insertion tube has been unsuccessful because of fixation. Fixation is the sensation that the colonoscope tube cannot be advanced because the colon is stuck in a fixed position. Normally, the colon can be felt to move and the bowel stretches on its mesentery with advancement or loop formation. This is something that is palpated by the hand that is advancing the colonoscope. If the colonoscope is felt to meet fixed resistance, then insertion must stop, even if the lumen of the colon is clearly in view. In this instance, it may be of value to switch to a thinner endoscope because the increased flexibility and reduction of force applied to the colon wall may allow the thinner instrument to be passed further without meeting fixed resistance. Having made these comments about the relative thickness and flexibility of the standard and pediatric insertion tubes, certain commercial colonoscopes are now available with a variable stiffness function. Using a dial on the control head, the stiffness of the insertion tube can be varied from a stiffness that approximates that of the most flexible pediatric colonoscopes to the stiffness that approaches the range of the stiffest standard insertion tubes that have been commercially available. Variable stiffness is most often employed as a method to reduce looping in the sigmoid after the sigmoid has been passed by the colonoscope tip. Thus, insertion begins with the stiffness device set on 0 or the pediatric colonoscope flexibility range, and the sigmoid colon is negotiated. After the colonoscope tip has been advanced beyond the sigmoid colon, the instrument is straightened and the device is activated so that the stiffening of the insertion tube may reduce the tendency of the colonoscope to form sigmoid loops. Many colonoscopists, myself included, like to have variable stiffness available and feel that in specific instances it seems to help colonoscope tip advancement. Here are some general observations about variable stiffness that may be of value to you. First, you are more likely to find the variable stiffness function valuable when using pediatric colonoscopes rather than standard insertion tubes. With standard insertion tubes, there are a greater percentage of cases where the tip can be readily advanced to the cecum without activating the stiffener, just because the thicker colonoscope tends to reduce loop formation in any case. Second, there will be many instances where activation of the stiffener seems to make no difference in colonoscope tip advancement. Therefore, colonoscopists must be skilled in the other ancillary maneuvers that resist loop formation, including position change and abdominal pressure. Third, I'm convinced that there are specific instances in which activation of the stiffener actually impedes advancement of the colonoscope tip. Therefore, if you have activated it to help pass an area of difficulty, and now you encounter another area of difficulty later in the examination and the stiffener is still activated, remember to try to deactivate the stiffener and place the colonoscope in the more flexible mode again. The data on the effectiveness of variable stiffness can be summarized as follows. There is no evidence that variable stiffness improves the success rate of cecal intubation. The data on reduction in cecal intubation times is quite mixed, but there probably is some improvement in cecal intubation time, particularly for trainees and people early in their experience of colonoscopy. There is also no clear-cut evidence of improved cecal intubation rates in patients with prior failed colonoscopies. A number of studies do show a reduction in the need for ancillary maneuvers, typically on the order of 10 to 15%, and particularly in the need for abdominal pressure. If I could summarize the situation, I would say that lots of people like to have variable stiffness available and believe that it helps, but the hard evidence suggests that there is only a mild improvement in colonoscopy insertion associated with variable stiffness. A very recently marketed development in insertion tubes has been called passive bending. This refers to a section of the insertion tube immediately adjacent to the bending section that has the property of distributing force over a longer section of the colonoscope when passing turns. The value of this passive bending development is not yet certain, but its presence is not expected to require fundamental changes in insertion technique. Returning to the issue of selecting the standard versus pediatric colonoscope, I mentioned that for routine cases, this selection is a matter of personal preference of the endoscopist. However, an effective colonoscopist must have a pediatric colonoscope available and be willing to use it in selected circumstances. The ped scope should be selected in patients who have known severe diverticular disease, known severe angulation in the sigmoid, or known fixation of the sigmoid, which sometimes occurs as a result of prior pelvic or abdominal surgery. The pediatric instrument may be a superior choice when unsedated colonoscopy is considered, particularly in women, because the increased flexibility reduces the pain from colonoscope passage. I prefer the pediatric colonoscope for all cases of Crohn's disease because of the ability to more easily pass strictures and enter the terminal ileum. The pediatric colonoscope is a wise choice when you have to get into the terminal ileum. For example, in the patient with unexplained abdominal pain and diarrhea, because it is just easier to enter the TI with the pediatric scope. I have a personal preference for the pediatric colonoscope for some cases of large sessile polyp resection because of increased maneuverability of the tip, including the ability to retroflex more easily in the cecum, the ascending colon, and the transverse colon. The pediatric colonoscope should also be selected when you know there is an increased risk of mechanical perforation. I include here radiation colitis, patients on chronic corticosteroids, and those with known colonic amyloidosis. The colon is more fragile in these settings, and the reduced forces associated with a pediatric colonoscope will likely reduce the risk of mechanical perforation. In fact, if you are using a pediatric variable stiffness colonoscope, I recommend not activating the stiffener when colonoscopy is performed for these indications. Before we begin colonoscopy, we must understand the operational features of the bending section, which directs the tip of the scope through the colon. Commercial colonoscopes essentially all have the same deflection properties when working properly and will allow 180 degrees of bending in the up direction and 180 degrees in the down direction. Right-left maximum deflection is 160 degrees in both directions. The control knob that is easiest to access is the up-down control. The bending head can easily be deflected in the up direction by using the thumb, but it is most easily directed in the down deflection using a combination of the thumb and the fingers, which pull the control knob down. And I believe this is also the most ergonomically sound way to manipulate the up-down control. Many colonoscopists manipulate the right-left control with their thumb also. My opinion is that for many of us, manipulation of the right-left control with the thumb is not an ergonomically sound maneuver. I prefer to take my right hand off the instrument shaft to operate the right-left control. There are two ways during colonoscopy to achieve right-left movement of the scope. One of these is by torque. In this maneuver, the colonoscope is deviated in the up-down direction, usually the up direction, and the instrument shaft is torqued with the right hand. This is a fundamental movement during both insertion and withdrawal of the scope. The second method, of course, is to deviate the tip using the right-left control. During insertion of the instrument, pain is related primarily to loop formation, but in some persons with sensitive or angulated colons, significant pain can be induced by torquing the instrument. Therefore, when pain during insertion is a problem, such as in the unsedated or lightly sedated patient, right-left deviation by use of the control knob may be more comfortable for the patient than right-left deviation achieved by torquing. True precision control of tip movement is best achieved by simultaneously controlling the up-down knob with the thumb and fingers of the left hand and the right-left knob using the right hand. In order to employ this two-handed control of the tip direction, we will need to learn what I refer to as the left-handed scope grip. Here is an example of a very difficult turn in the sigmoid colon that requires precise deflection of the instrument tip. In order to achieve this, we have placed the instrument shaft between the fourth and fifth fingers of the left hand. This maneuver allows us to continue to place forward force on the colonoscope using the left hand while simultaneously using the left hand to control the up-down control and getting precise tip deflection by using the right hand to control the right-left knob. You'll see me use this grip to achieve precise tip control during insertion, and in a separate DVD, I'll use it to achieve exquisite precision during the performance of complex polypectomy. The advantage of this grip, which I like to call the left-handed scope grip, is that it will allow us to achieve simultaneous insertion or withdrawal and precision control of the up, down, and right-left knobs. There is one additional point that I would like to make about tip deflection that is very important during colonoscopy. We discussed earlier that we can deflect the tip 180 degrees in the up-down direction and 160 degrees in the right-left direction. However, if we initially deflect the tip maximally in the up or down direction and then maximally deflect the tip in the right or left direction, the scope tip will hairpin. That is, it will look back at itself, but it will deviate very little from the up-down plane. This can be extremely useful in passing very sharp turns. With the scope passing through a turn in the maximum 180-degree up direction, the lens is against the wall. By deflecting maximum left in addition to maximum up, the tip now turns into the lumen, completing passage of the turn. Here is the real-time demonstration. We see the colonoscope tip passing through a turn in the sigmoid colon using what is known as the slide-by maneuver, which will be discussed later. Notice that the up-down control has been deflected maximally in the up direction, but by stopping and using the left-hand shaft grip and turning the right-left control toward the left, the lumen is brought into view. This hairpin maneuver is critical during retroflexed examination, and as we just discussed, it can be extremely useful in passing sharp turns during insertion. It's useful for a colonoscopist to know the standard information about landmarks, but I want to say at the outset that there are only two areas of the colon where you can reliably say that you know for sure where you are, i.e. what section of the large bowel you are in. One of these areas is the rectum and the distal sigmoid. The rectum can be recognized by its large luminal diameter and its distinct series of valves, but the most important indicator of the rectum is the distance from the external verge. The proximal margin of the rectum in adults is reliably about 15 centimeters from the external verge. You can pretty reliably conclude that you are at the rectosigmoid junction at around 15 centimeters and in the distal sigmoid at around 17 to 18 centimeters up to about 25 to 30 centimeters. Once the scope has been inserted beyond 30 to 35 centimeters, there's going to be uncertainty as to precisely what section of the colon the scope tip is in until you reach the cecum. The other area of the colon that we can identify with absolute certainty is the cecum, because no other area of the GI tract has the appearance of the cecum. To be certain we're in the cecum, we must see the ileocecal valve and its orifice, and we should also see the appendiceal orifice. Only occasionally is the appendiceal orifice completely obliterated by prior appendectomy. Intubation of the terminal ileum can help assist identification of the cecum, but it's not necessary for reliable identification. We can also be reasonably certain that we are in the ascending colon if the ileocecal valve is still visible to us in the endoscopic field of view. When we are outside of these regions, lesions that are sent for surgical resection, particularly laparoscopic resection, or lesions that must be identified on follow-up endoscopic examination, should be tattooed with carbon black. General clues to location include the following. The sigmoid tends to be tubular, narrow relative to the more proximal colon, to have multiple angulations on insertion, in particular compared to the descending colon, which tends to be straight, and in some patients, extensive diverticular disease is a clue to the sigmoid. With the patient in the left lateral decubitus position, the splenic flexure is often marked by a pool of fluid and a sharp angle. The transverse colon tends to be triangular, and because of its anterior location, light transmission through the abdominal wall and light moving across the upper abdomen with scope movement is a good clue. The hepatic flexure is often notable for the bluish color created by the liver on the opposite side of the bowel wall and its location adjacent to the ascending colon. The standard of medical care requires that a colonoscopist who sends a patient for surgical resection of a lesion accurately locate that lesion for the operating surgeon. Remember to never get cocky about where you think a lesion is located. If it's not in the cecum or in the right colon near the ileocecal valve, tattoo it. In the rectum and sigmoid, even though you may be confident that you know the section of bowel that the lesion is in, it's still often best to tattoo the lesion to make it very clear to the surgeon. Tattooing the distal end of a rectal lesion can help the surgeon to understand how distal their dissection must be carried. So we've done the history and the examination. The patient's given informed consent. We're ready to start the procedure. The first step in the procedure is always a careful rectal examination. So we're going to use a lot of lubricant. We want to do a quick inspection of the outside of the anus and the rectum, and then lube up, palpate the anal canal, and then do a full circular examination of the rectum. It's particularly important to examine the posterior fornix of the rectum. When the scope is inserted, it is directed toward the anterior wall, and the posterior wall in a very large rectum may not be seen well. A prostate exam should be performed, and the rectal examination results should be documented in the colonoscopy report. Now, we're ready to insert the scope. So we've got a lot of lubricant on the scope. We usually want to use our index finger to direct the scope up to the anus, and we want to point it sort of toward the umbilicus. During the rectal examination, we really can get a sense of the